Assalamualaikum and good day to all of you. My name is Nur Farhana Diana. I'm a senior lecturer and also a dietitian from Jabatan Pendidikan Awal Kanak-Kanak UPSI. So today I will give you a short lecture on nutrition for special needs children. In this lecture, I may use different terms for special needs children, such as people with learning disabilities and disabled children, but they all give the same meaning. For the introduction, people with learning disabilities are more likely to lack the sufficient nutrients for optimum health than the general population. Hence, poor health status would expose them to the risk of getting diseases. According to many studies, people with learning disabilities were deficient in their intake of magnesium, calcium, iodine, zinc, vitamin A, D, and E, and only 3.5% of people met the recommended dietary allowance for vitamin D. Despite these deficiencies, they may have sodium levels exceeded the recommended upper limit due to a high intake of processed meats, bread, and also pre-prepared meals. Malnutrition can be caused by oral motor difficulties such as dysphagia, which is a reduced capacity to chew and swallow that may require the texture of foods to be modified. They may have choking episodes, gastroesophageal reflux disease, dental issues, food allergies, side effects of medication, and also because probably they are on specialized diet where the food choice are limited, and these are all found with a higher prevalence in people with learning disabilities than in the general population. Other factors that cause poor diet of people with learning disabilities include poor health literacy, lack of knowledge about nutrition, they have poor food preparation skills, increased food fussiness, especially in autistic children, greater reliance on others to provide food that meets nutritional requirements, and because most of the disabled children, they are dependent on other people. Therefore, their dietary intake influenced by availability and accessibility of food at home, because they cannot go out and buy food by themselves, and also influenced by caregiver preference and caregiver food knowledge. If these children have nutritional problems, the parents or the caregivers must seek professional advice from a dietitian. Who is a dietitian? Dietitians must possess a degree in dietetics. Dietitians are qualified and regulated health professionals that assess, diagnose, and treat dietary and nutritional problems at an individual and wider public health level. They use the most up-to-date public health and scientific research on food, health, and disease, which they translate into practical guidance to enable people to make appropriate lifestyle and food choices, and they work at the hospitals, clinics, and private sectors. They can work in the food industry, workplace, catering, education, sport, and the media. Dietitians work collaboratively with families to develop strategies to help support patients' nutrition and feeding goals. They also offer personalized strategies to help to address any nutritional gaps that may exist whilst taking into account the patient's dietary requirements, food preferences, medical needs, and growth requirements. And also they advise patients on healthy eating habits that can prevent illness, help to achieve and maintain optimum health. Now I would like to discuss what are the common nutritional problems for children with special needs and what are the interventions that dietitians normally do. First problem is overweight and obesity. A child with special needs may have limited ability to do physical activity, therefore they are prone to be overweight. And research shows that about 20% of children aged 10 to 17 years who have special healthcare needs are obese compared with 15% of children of the same ages without special healthcare needs. These are among the factors causing overweight and obesity in children with disabilities: a lack of healthy food choices, difficulty with chewing or swallowing food or its taste or texture, medications that can contribute to weight gain and changes in appetite, physical limitations that can reduce a person's ability to exercise, a lack of accessible environments such as sidewalks, parks, and exercise equipment that can enable exercise, a lack of resources such as money, transportation, and social support from family, friends, neighbors, and community members, and the child with Down syndrome and mental retardation may be lacking a satiety sensation that leads to overeating. Interventions for weight management include dietary modifications, behavioral management, and increased physical activity. And we dietitians normally develop individualized nutrition care plan based on the following: the estimated energy needs, child's food likes, dislikes, allergies, and intolerances, families and child's eating patterns, child's feeding skills and mode of feeding, and also families' financial resources. Diet restriction is not advised for overweight children because we fear it may deprive them from other essential nutrients. Thus, the focus of the treatment is to increase physical activity, but for obese children, calorie reduction must be considered together with increased physical activity because we know that obesity can lead to other diseases. Thus, weight reduction is crucial. We also will advise parents or caregivers to do food modification, such as use low-calorie cooking methods, such as steaming, braising, roasting, or grilling. Remove all visible fat from meats and skin from poultry. Use low-calorie liquids, such as plain water or fruit juice without additional sugar. Limit usage of oil, sugar, mayonnaise, salad dressing, syrup, butter, and spread or toppings, and offer nutritious snacks such as fruits, low-fat or low-sugar yogurt, high-fiber biscuits, and bun. Besides, dietitians will provide counseling to family regarding positive feeding interactions, support for self-regulations of food intake, allowing food choices, and avoiding unnecessary rigidity or rules related to food. If child is ambulatory and able to follow instructions, then they are advised to increase daily activity, and they will be advised to reduce television and media viewing time. If child is quadriplegic or unable to move voluntarily, then the weight management is by diet alone. We move on to a second problem, underweight. Disabled children are 3 times more likely to be underweight and twice as likely to have wasting and stunting as compared to normal children. A recent review by Siti Fatiyah, Sue, and Divya reported that the range for overall prevalence of underweight among disabled children in South Asia was from 5.7 to 76.3%. Among causes of underweight include lack in nutritious food intake following their dependency on feeding and food preparation, multiple health conditions, frequent infections, as well as limited access to quality health care. Many diseases have higher than normal calorie requirements, therefore children with diseases, they are prone to be underweight, malabsorption, poor ability to eat, and also behavioral issues. For the interventions, dietitians may recommend nutrient-dense food for the underweight children. For example, we may add cheese into our scrambled eggs, add fruits to shakes, yogurt, pudding, use margarine, mayonnaise, cream cheese as spreads on bread or mixed with rice. We also encourage children to eat small and frequent meals to increase food consumption. Choose nutritious beverages such as milkshake, hot chocolate, soybean milk, or fruit juices rather than flavored cordial or carbonated drinks or coffee or tea. And once the child achieves the expected weight, healthy eating practice should be implemented gradually. Constipation is defined as incomplete or infrequent passage of stool persisting for 2 or more weeks, the presence of hard, dry fecal material with difficulty in defecation, even if passed frequently, may also be considered as constipation. A stool frequency of less than 3 times per week would be diagnostic of constipation in any age group. Causes of constipation may include inadequate dietary fiber intake, inadequate fluid intake, decreased physical activity, for example, due to prolonged illness, or maybe the child has a body cast on, impaired motor skills, immobility or paralysis, side effects of medications, irregular bowel patterns or toileting habits, maybe because of stress, underfeeding or malnutrition, abnormal anatomy or function of intestinal tract, and abnormal muscle tone leading to impaired function of the intestinal tract. Children with constipation will be advised to increase intake of dietary fiber, for example, from whole grain bread, cereals, fruit and vegetables or oat, increase fluid intake, serve food with high fluid content such as soups, fruits or yogurt, encourage the child to drink frequently between meals, a routine toileting schedule and proper positioning may also help, increase exercise or massage, or use of stool softeners or laxatives. Next common problem is diarrhea. Diarrhea is the sudden increase in frequency and looseness of stools. Diarrhea is sometimes described as the passage of more than 3 watery stools in 24 hours or 3 times the normal number of stools in 24 hours. The main complication of diarrhea is dehydration from the loss of fluid and electrolytes with the stools. Among causes of diarrhea are food intolerance. For example, the child may have lactose or fructose intolerance. Underlying diseases, the child may have cystic fibrosis, celiac disease, infections, and also medication side effects. For the intervention, parents or caregiver may continue feeding the child with small volumes but more frequently. Make sure that the child has adequate fluid intake. Use oral rehydration salts, ORS, based on the advice of a doctor, and also avoid food or drink that may cause diarrhea. Lastly, we have picky eating, which is also one of the common nutritional problems in children with disabilities. It is known that children on the autism spectrum are far more likely to experience eating difficulties, or commonly called picky eaters. Much of the eating difficulties experienced by children with autism is thought to be related to sensory processing differences. They may have restricted intake due to sensitivity to color, texture, temperature, or odor of the food. For some children, branding, product name, and packaging are important too. For example, they may eat the crackers from the green box but not from the red box. According to one study, fruits frequently reported in the diets of children with autism include dry cereal, which is eaten as a finger food, no milk added, crackers, chicken nuggets, pizza, bread, hot dogs, and plain pasta, while intake of vegetables and fruit tend to be minimal. And over time, some children narrow their food acceptance even more to fewer than 10 to 15 items only, Within that restriction, only certain brands or methods of preparation are allowed, and these can be detrimental to health because they are prone to micronutrient deficiencies. These are some of the interventions that a parent or caregiver can do at home. Keep offering the rejected foods along with his or her preferred foods. Do not force feed the child. If the child doesn't want to eat, then that's fine. You can try again later. Avoid using food as a reward. For example, some parents may give an ice cream if the child eats a vegetable. Avoid using this method because the child will be more attracted to the ice cream, not the vegetable. Set meal schedules. Parents eat together with children. You eat the same food that you want your child to eat. Limit grazing outside of meal and snack times because we want to make sure that the child is hungry during meal times. Limit beverages between meals, especially caloric beverage like milk, juice, or soda. Limit meal times to no more than 30 minutes. Explore foods outside of mealtime through activities like food play, food shopping, cooking, and gardening. Get creative with food plating. Avoid offering alternatives. For example, if the child doesn't want to eat foods that you serve, instead he or she wants something else, don't give in to the demand because this will increase pickiness or fussiness. But when you serve food, make sure that there is a food that the child will eat. Lastly, you can try food chaining. Food chaining is a approach that enables the child to try new foods that are similar to foods they currently enjoy and eat consistently. For example, here, the child loves potato chips, and the parent or the caregiver may try to serve something similar, for example, banana chips, and then later on, gradually, the parents can serve frozen banana, and then gradually change to a slice or whole banana. If you want to know more about child nutrition, you can follow my Instagram account at nd.childrens.nutrition. We have come to the end of this lecture. These are the references that I use in making the slides. Thank you.